Well, good afternoon, everybody. My name is Susan Webb. I'm chairing this ESE talk, which will be devoted this afternoon to adult growth hormone deficiency in adults. The speaker will be Luciana Martel, who has been the person who has been in charge of collecting all the data of this ESE survey and who was the first author on the recently published European Journal of Endocrinology paper, which summarized these results. Many of you participated in this survey, and I would like to thank everyone who did all the hard work of going through all their adults with growth hormone deficiency, collecting their data, putting them on the survey, and submitting them to the ESE. This idea of doing a survey started when a call was made by Pfizer for learning and education, and the ESE applied and was successful in getting this funding. Anyway, I will now give the word to Luciana Martel, an endocrinologist originally from Argentina, but who has spent the last years in Barcelona working at the Hospital de Sant Pau in the endocrine unit and in the pituitary research unit. Let me remind you that you're welcome to make questions, and the best way is to do it on the question and answer facility of this platform, and we will go through them at the end. So thank you all very much, and Luciana, the floor is yours.
Thank you very much, Susan, for your words. And good afternoon. First of all, thank you to the ESE for giving us this opportunity, and to everyone registering to this talk today. We are going to dive in our journey designing this audit, implementing it, and finally to its results. Also, before starting, I want to acknowledge the efforts made by all centers participating in this survey and making this possible. First, a few key concepts. Adult growth hormone deficiency, AGHD, affects between 200 and 300 patients per million population, approximately 100,000 patients across Europe. The condition is characterized by a reduction in bone mineral density, lean body mass, exercise capacity, and overall health-related quality of life, as well as an increase of body fat and an adverse cardiovascular risk profile. Evidence is nowadays overwhelming that most patients benefit from a daily injection of GH and that are willing to continue their treatment. Only a small percentage of patients do not perceive any benefit and prefer not to be GH replaced. Next, please. Current guidelines recommend that adults, patients with pituitary disease should be tested and treated for GH deficiency. On the other hand, AGHD is not universally recognized as a distinct entity, and reimbursement for GH replacement therapy is not available in some countries. Next, please. Therefore, ESE aimed to investigate the current practice of AGHD management to benchmark it against existing guidelines. For this, we systematically record current AGHD best practice from regional centers, representing several thousand individuals with either treated or untreated growth hormone deficiency. Secondarily, we wanted to compare and contrast practices of specialist experts, benchmark them against current guidelines, identify variances, gaps, and opportunities to seek improvement, and finally, to recommend findings to support local education to attain best practice, providing practical education and training opportunities. Next, please. We designed an online survey to collect information on diagnosis and treatment practices country by country on the basis of Kenhu published guidelines in 2007. The survey consisted of two types of questions. 24 questions collecting evidential information which gave us quantitative data about patients with growth hormone deficiency, adults, diagnosed and treated or not during a 2-year period, namely January 1st, 2017 and December 31st, 2018. They collected these questions, collected data regard to demographics, diagnosis criteria, patient selection, GH dosing, follow-up, safety, and treatment goals. This data provided the 80% of patient data sampling, and the other 20% was provided by 10 questions regard to the expert opinion of the center, which gave us qualitative data that reflected the practice and perspective of each center. This data was regarding national statistics on AGHD, country treatment, reimbursement policies, distribution of the drug, available education and training resources, and the level of satisfaction related to adult growth hormone deficiency in each local setting. Next, please. Patient data were collected in a 5-step process. First, individual patient data were captured in a dedicated access database or Form A supplied freely by the ESE to each center. Therefore, each center completed for each patient all the information required in this Form A. When all patients had been reported, the system generated automatically a summary of all aggregated data or Form B, which was the basis of the information submitted to the ESE in an online e-survey or Form C, which also captured the questions on expert opinion and the local environment regarding AGHD diagnosis and prescription in each country. Finally, the data were published in the European Journal of Endocrinology by the beginning of this year. And with this methodology, the individual patient data did not leave the center. ESE only saw aggregated data in the final e-submission form, so information regarding individual patient was kept confidential. Also, aggregating the local sample data systematically enabled ESE to compare it to identical data captured from other centers around Europe. Next, please. This was the welcoming guide for each center when they opened the dedicated access database provided by ESE with all the instructions. Here is the access to the Form A, where the centers reported all individual patient data. Once completed, one could generate automatically Form B, which summarized all reported data by clicking previous, please. Not yet. Thank you. By clicking here, centers were able to access to the link that guided them directly to the online survey, which was completed by the user using the information in Form B. And finally, the online survey was submitted to the ESE. Next, please. This is an example of how Form A for entering individual patient data looked like. And here, for example, they were able to introduce patient identification data. Down here, information regarding when the diagnosis of growth hormone deficiency was made, if they were ever treated, if they had another pituitary hormone deficiencies, and etc. Next, please. This is an example of how Form B, the automatically generated aggregated patient data, looked like. Up here, we can see that they were able to see the total number of patients that they introduced in Form A, and here the distribution of the data patients regard to depends on if they were diagnosed during childhood versus adulthood, if they were treated or not, if the treatment was ongoing by the time of the survey, or if it was interrupted, distribution regard to gender, etc. Next, please. And this is how the online survey or Form C looked like. I know that maybe you cannot see it properly, but I promise to the left is the welcoming message and further instructions. And to the right, you can see the first page where you can see some of the questions of the survey, which could be filled either with information in 4B, sorry, or information regard to expert opinion. Next, please. Originally, with this methodology, we aimed at collecting aggregated patient data of 5 to 10,000 diagnosed patients that represent around 5 to 10% of total adult growth hormone deficiency patients in Europe, Australia, and New Zealand. We finally fell a little bit short. We collected over 2,000 patients from Europe and 9 from Australia. Ideally, we will engage at least 1 center per small countries and 2 to 3 in large countries. Invitations to participate were distributed at the European Congress of Endocrinology in 2018 in Barcelona. Also through the Rare Endocrine Disease European Reference Network called ENDO-ERN and the ESE Council of Affiliated Societies, ECAS. Suitable centers were those from Europe, Australia, or New Zealand who currently treated at least 10 patients per year or who could not treat these hormone deficiency adult patients due to the local conditions and restrictions. We finally identified and invited to these 72 centers from 29 countries repeatedly via email. And the countries that were not contacted was because no potential participant was identified. Even though initially the idea was to include Australia and New Zealand, finally only 1 center from Australia was engaged. Next, please. This is a chart that shows the number and general characteristic of countries, centers, and patients involved in the study. We involved finally 28 centers from 17 European countries, a total number of AGHD patients of 2,139. 72% were adult onset, 28% childhood onset, up to 51% were male, another 38% were female, and in 11% their gender was not available. From the total patients, 85% had been ever treated with GH substitution and 15% had never been treated. They were treatment naive. From those who had received GH substitution by the time of the survey period, up to 84% were on ongoing treatment and 16% its treatment was interrupted by the time of the survey. Next, please. This is a map that shows the participation on the survey of different countries. Next, please. Based on the published prevalence of AGHD in different countries, this table shows the estimated and captured number of AGHD patients per country by our survey. As you can see, some countries in green collected significant amount of patients, as it was Denmark, which reported 32% of total AGHD estimated patients in its country. Also Slovenia, who reported 20%, Slovakia, who reported 8%, Sweden 14%, Bulgaria 7%, and Italy 6%. However, the majority in white of countries reported less than 5% of estimated global number of patients in each country. Italy was the country that provided most of patients to the database. They reported 622 patients and data came from 5 centers of Italy, as I'm going to show you later. And next, please. In order to evaluate the global experience of each center in the management of pituitary patients, we ask for a total number of pituitary patients as well as surgical and radiotherapy treatments per year per center, independently of their hormone deficiency status. On this first slide, those centers with the highest workload, that is following more than 500 pituitary patients per year, are shown. In light blue, we can see the numbers of patients per center per year regard to pituitary patients. In green, the number of pituitary surgeries. In orange, pituitary radiotherapies. And finally, in purple, the number of AGHD patients per center per year. These centers were named according to their location. They were Stockholm, Messina, Marseille, Genova, Turin, Ljubljana, Lyon, Barcelona, and Sheffield. Next, please. These are the same results, but in those centers that declare to follow between 5 to 100 pituitary patients per year. This included Sofia, Athens, Zagreb, Milan, Aarhus, Bucharest, Thessaloniki, Santa Cruz de Tenerife, Bratislava, and Basel. Next, please. Finally, the smallest centers that declare to follow less than 100 pituitary patients per year per center, represented in the same way, and these included Split, Madrid, Budapest, Modena, Belgrade, Alicante, Kaunas, Novi Sad, and Porto. Next, please. In this slide are shown the results of frequency of etiology of the adult growth hormone deficiency. The most common cause was a non-functioning pituitary adenoma in up to 26% of all cases reported, followed by craniopharyngioma and genetic or congenital midline malformations, 13% each. Furthermore, other causes were from most to least frequent: other pituitary mass lesions as cyst or inflammatory disease, prolactinoma, cranial irradiation due to another malignant disease, Cushing's syndrome, vascular causes, idiopathic isolated growth hormone deficiency in 4%, traumatic brain injury, and treated acromegaly in 2%. These results were congruent with that reported by the guidelines. And interestingly, in 81 patients, which is a 4%, the cause reported to be the cause for the growth hormone deficiency was an idiopathic isolated adult growth hormone deficiency, which is an entity not recognized as occurring de novo in adults according to the guidelines. Next, please. Regard to other pituitary deficiencies, only 8% of patients had isolated growth hormone deficiency, while other patients had multipituitary or hormone deficiencies, which were deficiency of TSH in 82%, LH-FSH in 76%, ACTH in 70%, ADH 22%, and prolactin deficiency in 7% of patients. Next, please. Diagnosis of growth hormone deficiency was confirmed by a stimulation test in 52% of the patients. In the vast majority, it was made through a stimulation test considered valid in adults according to the WHO guidelines, mainly a GHRH plus arginine test in 44%, an insulin tolerant test in 42%, and in 7% a glucagon test. Besides, another 7% performed to diagnose growth hormone deficiency other tests not considered valid in the guidelines, which are GHRH alone and clonidine test. Also, in 14% of the patients, their centers reported not to be necessary to perform a stimulation test since the patients had 3 or more pituitary deficiencies plus low serum IGF-1, Unfortunately, in 34% of the patients, there was no data reported regarding how the diagnosis was made. And finally, since GH therapy is not an indication in pituitary patients with isolated GHD, 34% of centers do not, as a rule, perform a stimulation test in these patients. Next, please. The diagnosis cutoff values for GHD, as we know, vary in the different consensus. While the European consensus uses a threshold of lesser than 3 micrograms per liter, in the US, it is considered to be the cutoff lesser than 5 micrograms per liter. And the great majority of the centers agreed with the European consensus. However, 3 centers accepted the Endocrine Society cutoff. On the other hand, GHRH plus arginine test is considered BMI dependent as reported by the guidelines, and the cutoffs accepted by the guidelines also are lower than 11 for patients with a BMI lesser than 25, lower than 8 for patients with a BMI between 25 and 30, and lesser than 4 for patients with a BMI greater than 30. However, some centers consider other cutoff. For example, one center in Denmark considered the only one cutoff of lower than 6 micrograms per liter, irrespective of BMI. And all centers in Italy consider the cutoff of lower than 9 in patients with a BMI lesser than 30 and lower than 4 in patients with a BMI greater 30 or greater. Next, please. As we know, indication of different stimulation tests may vary according to specific situations. And according to the results of our survey, for example, in patients aged above 65 years old, the preferred test by the centers was a glucagon test. In patients with obesity, most centers perform as a first choice an ITT test in blue. And in patients who had the history of prior cranial irradiation, also the preferred test was an ITT, while in patients with epilepsy, as we know, the ITT test is contraindicated, the preferred test was a glucagon test. Finally, in patients with a history of ischemic heart disease, the preferred test was again the glucagon test. Next, please. This slide is showing features considered by centers when wishing to initiate GH substitution therapy. On the left are shown the requirements that each center considered necessary for starting the replacement. Up to 75% of the centers consider necessary the presence of patient compliance. 43% consider necessary the impaired quality of life, 32% severe fatigability, and in lesser extent, 11% each that age younger than 65 years old, and the presence of central obesity. In Madrid, also, they consider necessary the presence of bone mineral decreased bone mineral density, and in Athens, no current or prior history of malignancy. To the right, we can see factors that prevented to initiate the GH substitution therapy, and we can see that in up to 10% of patients that were not treated, the main cause was the presence of administrative issues, which is the lack of reimbursement and restrictions to provide the drug in hospital pharmacies. Also, the cause that stops to initiate the GH treatment was in 6% of the patients, the compliance considerations, and in lesser than 5%, the cause that stopped for initiating the treatment were persistent and stable pituitary tumor rest, age above 65 years old, concomitant diabetes mellitus between others. Finally, a low baseline IGF-1 level was required to start a GH therapy in 2/3 of the centers, despite the guidelines state that normal IGF-1 does not rule out GHD at any age. Next, please. This is a chart that shows the numbers of patients with adult growth hormone deficiency per center who were treated. In purple, those with adult onset, and in green, those with childhood onset or not treated in red. In some centers, as we can see, percentage of treated patients was high at the top of the chart, as it is in Aarhus, Stockholm, Barcelona, Genova, Bratislava, Santa Cruz de Tenerife, Zagreb, Lyon, Sheffield, and Milan. As the opposite, there were centers who treated less than 50% of their patients, which are depicted at the bottom of the chart, as were Belgrade and Novi Sad from Serbia, Porto, Bucharest, Thessaloniki, Sofia, and Sydney. In these countries, administrative reasons contributed to low percentage of treatment, since it was reported that AGHD is not an approved indication for GH therapy reimbursement in Romania. In Lithuania and Portugal, reimbursement for adults was only recently approved. In Greece, hospital pharmacies are reluctant to supply treatment for budget reasons, despite approval for the indication. In Bulgaria, full public reimbursement is only approved for those with childhood onset. In Slovakia, reimbursement is only partial, and in Hungary, only few endocrinologists who work at accredited GH centers are allowed to prescribe reimbursed GH substitution for adults. Next, please. As far as the initial GH dose, it was smaller in older patients, and in contrast with the guidelines, only in patients younger than 25, women received higher doses than men, what did not happen in patients older than 25. In Portugal, interestingly, GH dose was prescribed based on body weight, although this is not recommended in the guidelines. 60% of patients were recommended to administer GH injections in the evening, which agree with the guidelines. Next, please. During the survey period, some patients diagnosed with adult growth hormone deficiency had interrupted treatment due to these causes. Up to 57%, this cause was the presence of some adverse event. In another 22% were lack of compliance. In 19% were administrative reasons. In 80%, lack of positive effect perceived by the patient, and in 12 patients, which is 4%, the reason for stopping the treatment was its death, which does not mean that they were related directly with the GH therapy. Next, please. Of the 594 childhood onset adult growth hormone deficiency patients, in near a third, GH substitution was interrupted during transitioning period to adult care for more than 24 months. And these were the main reasons. In 33%, the reason for stop the treatment and being interrupted so long was the lack of reimbursement. In another 30% was the patient electing to stop the treatment, and other causes less frequent were discharged by the pediatric consultant, poor patient compliance, and difficulty in referral to an adult clinic. Next, please. Regard to the follow-up and monitoring replacement efficacy, in 83% of patients, IGF-1 levels were maintained within the age and gender-related normal range. In most centers, IGF-1 is measured 2 to 3 months after initiating treatment and every 12 months once stable. Other efficacy variables reported in approximately a half of the patients were body weight, hemoglobin A1C, blood pressure, BMI, lipid profile, bone mineral density, and body composition. Next, please. Finally, an attentive questioning to assess quality of life, as is asking for overall well-being and energy level, were routinely questioned in only 61% of patients, while the number of sick days and partner satisfaction were recorded in less than 11%, although considered essential in guidelines. In 45% of patients, a specific quality of life questionnaire was administered, mainly the quality of life assessment of GH deficiency adults questionnaire, the AGHDA. Interestingly, in the United Kingdom, impaired baseline quality of life using the AGHDA questionnaire is a prerequisite to initiate GA substitution, and quality of life is supposed to improve. While in other countries, however, quality of life questionnaires are not used, which is in accordance with current guidelines. Next, please. This final slide regard to our results refer to the level of satisfaction of centers regard to their local resources as education, postgraduate training, and awareness of adult growth hormone deficiency of healthcare professionals. Centers were asked six questions, which were overall quality of this patient's treatment in your local setting, extent and quality of nurse training, AGHD awareness by non-endocrine healthcare professionals, extent and quality of patient information resources, extent and quality of postgraduate AGHD curriculum training, and all patients in your country are undergoing optimal diagnosis and treatment according to the latest best practice guidelines. In green, we can see higher levels of satisfaction, and in yellow, orange, and red, lower level of satisfaction. 18 out of 28 participant centers were satisfied with overall quality of AGHD patients management, and especially with the extent and quality of nurse training. However, people were not satisfied in general with AGHD awareness of non-endocrine healthcare professionals, and there was plenty of room for improvement in the curriculum of postgraduate training related to adult growth hormone deficiency. Next, please. As far as strengths and limitation of the survey, we consider that some strengths are collecting real-life data from clinical centers responsible for diagnosis and management of adult growth hormone deficiency. Also, identifying country-specific differences in the diagnosis and management of this disease. However, some limitations were that variable participation in different countries. We observed that also Australia and New Zealand were not included. Finally, not all centers reported data on non-treated AGHD patients. Patients with organic isolated AGHD could be underdiagnosed and not reported, and centers with less experience in the diagnosis and treatment of this disease were not included, since we included only those with diagnosed more than 10 AGHD diagnosed patients. Next, please. The important points for this survey can be summarized in that, considering the gap between the estimated and captured AGHD patients across Europe, growth hormone deficiency in adults is more prevalent than currently thought. Therefore, awareness should be raised in the medical community and the health policy officials and funding bodies. Guidelines are followed to a large extent. However, we found several exceptions. Equality of healthcare in Europe for rare diseases is an aim that is not globally guaranteed for adult growth hormone deficiency. Next, please. How can the ESE help countries developing AGHD best practice treatments? Updating the guidelines, given that the current guidelines were published in 2007 and 2016, and that since then, further data on efficacy and safety on GH therapy in these patients have become available, confirming the benefits of the treatment, also encouraging patient support, the supporting organizations, since sharing experience with other patients can be very helpful, assisting the education of patients, updating recommendations, and running an ESE clinical update workshop locally or regionally, and finally encouraging educational learning and changing behaviors to the non-endocrine healthcare professionals. Next, please. Thank you very much for attending today. Susan?
Well, thank you very much, Luciana. That was very clear, and thank you very much for putting this talk together. Let me remind all participants that you are welcome to either raise your hand electronically or use either the chat or the question and answer facility on the Zoom platform to, if you would like to highlight any of the issues that have been talked about this afternoon. I think that one of the things that has come out of this survey, and which is something that we endocrinologists know about or are knowing more and more about, but that is still considered, let's say, a second line therapy or not such important therapy, are for the non-endocrine specialists or the health planners. And this is important because if instead of talking about growth hormone deficiency in adults, we were talking about a new antibiotic for specific infection, probably things would be different. But anyway, I think that the fact that growth hormone requires a daily injection and that patients on the whole want to continue on treatment means that these patients really are finding an improvement, and that therefore that they want to continue therapy. Okay, I think we do have a question here. Well, actually, it's just a comment for you, Luciana. That was very clear. Thank you very much. We have now a question from Camilla Shalin. Hello, Camilla from Finland. And she suggests that for guidelines, it would be important to comment on which stimulation tests are considered reliable. Well, I think that we were surprised to see that even though most centers used what we call reliable tests, there was 7% of the centers that had based the diagnosis on a clonidine test or GHRH alone, which are not considered standard or reliable or valid tests in adults. But having said that, that was only 7% of the cases, while all others either did not perform a test because patients had panhypopituitarism and a low IGF-1, or that is more than 3 other deficits, or plus a low IGF-1, or else they used a GHRH and arginine, or an insulin tolerance test, or a glucagon test. We have 2 other issues here. Krista van Bonderen asked whether there was data on treatment above 65 years the same satisfaction by patient or doctor or never treated? I do remember that 65 was not an indication to stop treatment, and we do have patients in the survey treated over the age of 65. Luciana, can you remember more details of how many there were? Or I don't think we did not separate.
Not exactly.
No, we did not separate, say, the results in the older than 65 versus the younger than 65, even though this could be done. But
Yeah,
yeah,
you're right,
around
Susan.
the
We
age-
don't have that information, and it will be interesting,
yeah.
certainly. Yes.
Certainly there were patients over the age of 65, and my personal experience is that on the whole, many of them do benefit also from growth hormone substitution therapy if they do have symptoms related to adult growth hormone deficiency. We have another question from Kevin Nguyen. Why do you think there is so much variability in growth hormone stimulation testing and cutoffs in the different countries, despite well-stated cutoffs stated in the guidelines? Well, the guidelines don't agree because in Europe, we usually follow the less than 3 for an ITT, and in the US, treatment is allowed, or you can diagnose growth hormone deficiency if the response to an ITT is less than 5. And why do we use 3 and 5? Well, these are agreements that have been reached, but there is not much more evidence than that. And as far as the BMI or age-related cutoffs for the GHRH arginine, well, we were also surprised to see the differences in the different countries and the different centers. But I guess it's a challenge to really consider that one criteria should be better than the others.
Susan, do you remember that we, in fact, were surprised too because of that different cutoffs? For example, in Italy and in Denmark, and they told us that this was because of reimbursement policies. So funding policies put these cutoffs, so they have to proceed the same way.
Yeah. Yeah, so in Italy, they've come to a sort of a more practical solution, and they use less cutoffs than described in the baseline in the guidelines for reimbursement, obviously. And as Luciana said, yes, in Denmark they also had let's say less complex cutoff requirement, which was linked to reimbursement of growth hormone by the health authorities. We have another question from Kevin Nguyen. Do you think that when long-acting growth hormone formulations become available, that there will be an increase in testing and use of growth hormone across some of the lesser used growth hormone countries? Well, I guess it depends a lot on pricing. If weekly growth hormone is of a not higher price than weekly or than daily growth hormone, it certainly will be a good possibility for patients, because they often ask you if there isn't some treatment which could be administered less frequently than daily. But the big question will be what the price will be of this weekly growth hormone. If it's much more expensive, I know at least in Spain, it will probably not be authorized, despite being an advantage. And this will be a health policy and have to come to some sort of agreement with the drug companies. That would be my point of view. Let's see. These questions we have another here in the chat. Okay, also from Camila Shalinienti. She says there are some, in inverted commas, tired people who, for instance, claim that the GHRH arginine is not reliable and only want the ITT. They refer to the US guidelines. I guess tired people who have failed to be diagnosed with a GHRH arginine test and want an ITT. Well, many tired people in the world. I don't think that growth hormone deficiency can be diagnosed if people are just tired, especially if they're not in the clinical context of pituitary disease. And I think that we have to be very firm here. And this is definitely not a cosmetic or a sort of alternative treatment. I think patients that are growth hormone deficient in a proper clinical context do benefit, but for just tired people, I would not. I mean, I wouldn't be allowed to treat patients in that situation in my country. Good. Camilla agrees, you just have to know how to tackle it. Well, it sometimes takes a lot of patience and a lot of talking to patients, a lot of patience, being patient, but also you have to talk to the patients and try to explain to them that, well, if it's not indicated, it's not just to make them unhappy, but because there is a reason behind. I know it's not always easy, but that's what I guess we have to do if we are responsible. Let's see if there are any further questions or in the chat. I can't see them. Well, if there are no further questions, I'd like to thank you very, very much, Luciana. I know you've worked hard to make this presentation clear, and I think we all agree that it has been clear. And I would again like to thank the ESE for allowing us to apply for this grant, Pfizer for funding this audit and survey, and all the participant centers who provided their data, which we have presented in a summarized way today, and then to all the attendants. I've been checking the numbers and I've seen that there were more than 70 at a time, so that is really fantastic. And also all of those who have asked questions and contributed to the distribution, to the discussion. So thank you all very much indeed, and I look forward to seeing you all at another ESE talk. And thank you, Vicky, thank you, Claire, for technically allowing us to put this talk together. Thank you all very much. Goodbye.
Thank you, everyone. Good afternoon.